Welcome to tonight's Immunisation Coalition webinar event. The topic for this evening is what's new in vaccination against zoster. My name is Andrew Minton. I work for the Immunisation Coalition and I am the Education Manager. Just to go through tonight's format or program, I'll just start with introducing the welcome to country. There will be some housekeeping items. I'll then introduce our guest speaker, Associate Professor John Litt, and then Professor Litt will take us through his presentation, which will take about 40 minutes. And then we'll have a Q&A session of about 10 to 15 minutes, and then I'll wrap up. I'm very keen to finish at 7 p.m. Just to respect everybody's time. We all have families. It's all at 7 o'clock. It's about dinner time, and for some of you, you may still be at work. So firstly, I'd like to acknowledge the traditional custodians of the various lands of which we work, and any Aboriginal and Torres Strait Islander peoples that are currently on this webinar. The Immunisation Coalition welcomes you. I pay my respects to elders past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the animals, the land and waters of Australia. So we're really quite fortunate tonight to have an eminent speaker. As I said, Associate Professor John Litt. He'll be presenting on shingles. He brings with him a wealth of experience and clinical knowledge, and we're very lucky indeed to have him present tonight. As usual, if you wish to ask any questions, and we do encourage you to ask questions, please use the Q&A function at the bottom of the screen. If you wish to use the chat function, that's also fine. And please make comments yourself, and anyone else that wants to comment or feedback, please do so. I'll be reading out the questions at the end of Professor Litt's presentation. Now, if I'm not able to get to all the questions, and I'll try and get through as many as possible, we will keep a record of all the questions. We'll probably group them together, and we'll provide answers back to everyone that has registered for this event in about a week's time, together with the recorded webinar, which will be also available mid next week through a direct email to you, as well as on our website. This is a recorded webinar, as I said, so all participants will be on mute. And as I said, I will try very hard to keep to the 7 p.m. Deadline to respect everybody's time. So with that, I'd now like to introduce our guest speaker. So Associate Professor John Litt is from Adelaide. He's a retired academic GP and public health physician in the discipline of general practice at Flinders University, and was the Deputy Chairman of the National Quality Committee of the RACGP for 18 years. His major clinical and research interests are in prevention and its implementation. Associate Professor Litt has over 130 peer-reviewed publications, including but not limited to a number of high-quality journals in publications, as well as a number of books and book chapters. To his credit, he conducted the first Australian National Influenza and Pneumococcal Survey in older adults in 1998, and in 2009, the first Australian Zoster Attitudes and Beliefs Survey in older persons and GPs. More recently, he helped develop an online COVID-19 risk calculator called Coracle, which is also available on the Immunisation Coalition website, which assists in patient decision-making processes for COVID-19 vaccination. John has been a member of several national committees and consortia and scientific advisory committees, including, but not limited to, NHMRC, ATAGI, Cancer Australia, and NCIRS. And he was one of the inaugural directors of the ISC, the Immunisation Specialist Group, which we now know is called the Immunisation Coalition, and is currently a member, in fact, he's an active member of the Immunisation Coalition Scientific Advisory Committee. So a huge thanks to Professor Litt for dedicating his time tonight, and also in the time leading up to tonight where he's spent time on his presentation. A very warm welcome to you, and without further delay, I'd now like to hand over to John to take us through his presentation on what's new in vaccination against zoster.
Thanks, Andrew. I just need to sort out sharing my screen. Let's see. Can everybody, I'll just go to the thing. Can everybody, let me know if everyone can see that. So here are my conflicts of interest. I'm not going to karaoke the slide, but largely I talk about vaccines that are currently registered by the TGA and or on the National Immunisation Program, and I do it across mainly vaccines for adults and older people because that's a group that often get neglected. Andrew's covered most of the other things for there. I'm not receiving any payment for doing the session for this evening. It's quite a busy agenda, and I just want to remind people about some other risk status issues for zoster and the burden of morbidity. I'll give you a quick highlight on ophthalmic zoster because I had a chance to do that at the recent College of GPs meeting in Wonka in Sydney in October. Particularly, I'm going to focus on the recombinant vaccine. So that has now become the vaccine available for zoster, largely as of the 1st of November, and the guidelines have changed, and I'll go into that in some detail. I'll also share some information about immunocompromised people because they now are a group that are actually eligible on the National Immunisation Program, and there are 4 main groups in the first instance, and we'll talk a bit about those groups and how well the zoster vaccine works in those categories. I'm going to talk about coverage, and clear to my heart is that we actually have a very expensive vaccine, but we need to make sure that people get it. The really good thing about this vaccine is it's a vaccine in older people where we get a vaccine effectiveness above 90%. Now, that's been unheard of until recently, and that vaccine protection lasts for at least 10 years and probably longer. So, it is a very good vaccine, but how do we maximise it? And while the starting gun is gone, it's clear that there are a few issues with supply in terms of actually getting it out to GPs and how you might best run that. And I'll talk about some of that, which is going to be based on the zoster attitude study I did over 10 years ago. And while that was with the live attenuated vaccine, I think the lessons learned from that are very similar. So zoster's on the increase. And the other take-home message from this is people keep thinking, am I going to catch zoster? Well, 95% of the population over the age of 35 have got serology evidence that have actually had varicella. And so that actually clearly indicates that we're all at risk. So if you go and live in a cave on South Georgia, you can still get zoster. You don't need, like a lot of the respiratory viruses, someone to trigger it. And what does trigger it is increasing age, where your immune system declines. And I'll talk a bit more about that later. But we're not alone. Now, in every country, it's on the increase. And you can actually see it's proportionally on the increase in those over the age of 50. In fact, you can say for about every 15-year decade from the age of 50, the incidence of zoster doubles. And so by the time a person gets to 85, 1 in 2 people would have had zoster, and your incidence of getting zoster in your lifetime for the whole population is 20 to 30%. So it's very substantive. That's kind of said to this in another sort of way. I guess what's alarming from our survey is a lot of people don't think they're going to get it, which is why I talk about the coverage issue, is that 95% of people have had it, and so they're all at risk. If we take a person who's over the age of 60, which is just below the threshold that ATAGI has said of actually being eligible for the NIP, your lifetime risk from then on is about 40%. More importantly, one in 10 of those group are going to get postherpetic neuralgia, which is a really nasty complication. And that rises dramatically. So you can see by the time you're an 85-year-old, that risk of PHN is doubled. And so PHN is a very problematic issue to treat, and the best way of sort of dealing with is to avoid it. This is a bit of a complicated slide. It's a systematic review looking at the risk factors. And the 2 that stand out are age, and I've already highlighted the over 50s. The other thing is immunocompromised. And so the kind of standout ones are where we're now going to be offering the vaccine. But things like HIV, solid organ tumours, other malignancies, blood cancers, your risk is clearly increased. Just note also that a family history puts your risk up. And if you can read the sort of tight graph here summarising the systematic review, you can actually see gender is also an issue, so that women actually have a higher incidence than men in terms of actually developing it compared to 1.19, sort of about a 90% increase risk on chaps of actually getting Zoster in their lifetime. There are a range of other conditions where the risk is a bit higher, and we'll tackle those a bit later on. So we've all seen it. It starts as pain. It takes a couple of days for the virus to track down one of the sensory nerve roots, and so that could be 2 or 3 days before that appears. The virus has been harvesting in the dorsal root ganglion, and what happens is that when the immune system declines a bit and largely your T cell surveillance is wanting, the virus will start to multiply. It'll cause a ganglionitis in that dorsal root ganglion. As it travels down the nerves, it gives that very sharp neuropathic pain, and then a couple of days later, within that dermatome, you'll see the classic vesicles on an erythematous background, and over the period of 3 to 4 weeks, they will gradually crust and then heal. And so, typically it's lasting about a month, and the pain can be very severe. The complications of that, which we'll talk about in more detail later, is things like post-hepatic neuralgia, which is not uncommon, and then ophthalmic zoster. The complications are actually more common in people who actually have ophthalmic zoster. Now, I've got to be careful with this one, being a male, is that various groups have actually had a look at the pain, both with acute pain and with chronic pain. And you can see in the acute setting that zoster is comparable to labour pain. And you can see in the chronic pain conditions that some of those things that we're familiar with. Now, post-hepatic neuralgia is actually quite severe in terms of the severity with a lot of other musculoskeletal issues. And so, both these pain conditions are problematic. The main complications, you can have cutaneous things there where you can actually get a change in sensation. You can get secondary infection because the vesicles get infected. And then there are a range of ophthalmic, neurologic complications. The chief one is post-hepatic neuralgia, and the incidence of that rises as people get older. The other thing just to be mindful of is the risk of stroke actually also goes up, and I'll talk a bit more about that. It's even more common after ophthalmic zoster, and it actually is reduced by getting a vaccine. Ophthalmic issues largely are progressive if you get it. So somewhere between 8 and 20% of people who get acute zoster will get ophthalmic zoster. And it starts at the front of the eye and then works its way back, and I'll talk a bit more about that later. You can actually get disseminated zoster, particularly if you're immunocompromised, and you can get recurrence. So that typically about 6 to 8% of the population over a 10-year period might get a second bout of zoster with time. Sometimes the zoster actually comes without the rash, and we call that zoster sign hepet, which means without the spots. That can make it very difficult to actually interpret that, but most of the time it can be done on a clinical assessment. So what about the risk factor for post-hepatic neuralgia? Increasing age, the greater severity of the pain, the duration of that. Reassuringly, there's no incidence which is increased for PHN for people who are female or with immunocompromise, or which dermatome is affected. And similarly, whether you've had depression or cancer, whether that increases the risk, there's no clear evidence of that. So look at the burden of this by age, and that's just another way of putting that initial graph where I showed you how it increases, is that our older population are particularly at risk. And what's been very reassuring with the government having to include now anybody over the age of 65 as eligible for a free recombinant zoster vaccine, is that the over 80s can now finally get access to it without having to pay a sizable amount. And that is well worth offering because they have a high incidence of zoster, and you can see the dark blue, a high incidence of PHN. So what about PHN? What's the kind of prognosis of it? So this is just a graph showing a US study where they actually looked at the people over a period of time, and by definition, PHN is defined when you've had it continuously from 3 months since the onset of that. And so you can see in this particular cohort, it's about 20%. But you can see over the 4-year period, the incidence of that really only halved. So a lot of these people have this pain for a very long period of time. Hopefully it will clear up in some, but it is one of the 2 commonest conditions actually seen in the chronic pain clinics alongside diabetic neuropathy. So it is problematic to treat, and it's not going to go away in a hurry. The other thing about the pain is because it's a neuropathic pain, it has all of these other characteristics. So people have mood changes, with anxiety and depression. They have a change in their sleep pattern. They actually have functional limitations, particularly if you've got ophthalmic zoster in the first nerve of the first division of the trigeminal nerve, that brushing your hair is very uncomfortable because of the change in sensation to that. And so this has a social impact. So it's not just the pain. The pain specialists have told me that quite a few people who are elderly who've actually had zoster go from being independent to actually being much more dependent because of the impact of these complications. Now, this is ophthalmic zoster in a nutshell. So it can be quite tricky to diagnose. It's in the first division of the trigeminal nerve. There is a classic sign that we've all learned about as medical students, Hutchinson sign, where you get some pain at the tip of the nose and vesicles, which is the start of the rash there. The pain, the discomfort for ophthalmic zoster can be quite, it may be eye pain, it may be headache. In terms of it works through the eye from the front of it. So often you're getting conjunctivitis and local swelling. The next thing to happen is a keratitis of the cornea. And as it moves back, they get a uveitis, occasionally episcleritis, and they can actually get retinal necrosis occasionally. Now, about 1 in 10 of the population who get ophthalmic zoster will have some degree of visual loss, and 90% of this is the impact of the quite devastating keratitis and the opacification of the cornea. So the antivirals you can see here work by about 20 to 30% if started promptly, and they need to be used systemically. But largely someone with ophthalmic zoster needs to see an eye doctor with urgency, and they need for follow-up because some of these more deeper eye complications take 3 or 4 weeks to occur. And so even if they have an initial assessment, they're going to at least need a follow-up, possibly 2, to ensure that things are actually evolving and getting better if they didn't get the vaccine with antivirals, but ideally with the vaccine. And we can see with the recombinant vaccine, we've got somewhere between a 67 and 93% effectiveness of actually preventing ophthalmic zoster in the first place. So the best message is to try and prevent it. So I've mentioned about the risk of stroke and also heart attack. That's in the first 3 months, and it's thought to be the inflammatory response to shingles. We've seen a lot of the work that Ryan McIntyre has done on how the inflammatory parts of influenza increase the risk of a coronary disease. Well, zoster is actually particularly neurotrophic and seeks out nerve tissue, and so that's been seen to be the underlying kind of biological mechanism. And so you can actually see in this group of what happens with zoster, and you can see what happens with the vaccine. So you can see this Kaplan-Meier curve here is that the greatest benefit from people of getting the vaccine is in the people that are in the 60 to 70-year age group. Those older than that, their risk of stroke is slightly reduced compared to those that are not vaccinated, but particularly in those people in the 60s, that's seen. And more recently now, we actually have evidence from both the initial live attenuated vaccine. So there was about a 23% reduction from having the live attenuated vaccine. That's closer to a 50% reduction, which is largely taking it back to the risk of the population who haven't had zoster. This is just highlighting a recent review in the American Heart Journal, and the bottom line here is highlighted in the red rectangle. And you can see with increasing years since you've had zoster, while the risk does decline, there is ongoing risk of actually having a stroke over that period of time. So in addition to the initial risk. Now, this is cohort data. It's not randomized controlled trial, but the risk is both acute and ongoing. So what happened on the 1st of November? The government, after a lot of deliberation, have now actually totally replacing the zoster program, the live attenuated vaccine, because of its risks associated with immunocompromise, now with the recombinant vaccine. And the recombinant vaccine means that people will not get a bout of zoster or varicella from actually having the vaccine. So it's going to be available for everybody over the age of 65 years. It'll be available for our First Nations people, for those over 50. And there are 4 main groups at the moment that it's been indicated, with a view to have a further look at other immunocompromised groups in the near future. And this is going to cost something like about $800 million over the next 4 years. So people have had a stem cell transplant, which is happening a lot more for people with hematological malignancies or other conditions, solid organ transplants for a lot of the blood cancers, and particularly advanced or untreated HIV. We're somewhat lucky in Australia that most people actually are treated, and it's interesting they've made that sort of indication of people who are advanced or untreated. So it's the vaccine, how it differs from the live attenuated vaccine is there are 2 components to this vaccine. They've actually got the epitope, which is what the immunologist and the people working on developing the vaccine choose as an area on the virus to target, because it's usually maintained and it's very immunostimulating. And so they found a glycoprotein on the varicella zoster virus, which was a good target and actually provided a good trigger to the various dendritic cells and macrophages that actually encounter that. And that whole process is enhanced by a new AS01 adjuvant, which is a kind of lipid protein combination in addition from the qualia bark. That is actually means that whole presentation of the vaccine to the immune system results in a very large response. So this is shown schematically. By adding that adjuvant, you get a much bigger response initially, which means that there's a slower transition to a threshold where you're not going to get protection. And not only is the progression much slower, but it also means that the duration of response is going to be much longer lasting. So the 2 pivotal studies were known as the Zoe 50 and the Zoe 70. They did the second study because that's where most of the PHM was, and they wanted to get larger numbers, so they had a robust statistical analysis to look at the results. They effectively had 30,000 people enrolled in the study, where nearly over 16,000 got the vaccine in these 2 age groups, and in some of the situations they actually combined the two groups to actually look at the particular much rarer endpoints. Here are the pivotal results, and these are the results out to 4 years, which is where the prime endpoint was published. Tony Cunningham had a very large role in that and was the lead author on a number of the papers. The really reassuring thing you can see this is the vaccine effectiveness is above 90% right out to the age of 80. In the people that are up to the age of 70, that's averaging around 95%, and slightly lower in those over 70, but still the confidence intervals overlap. And if you remember Zostavax was about 50% effective in preventing shingles in those 60 to 69, and it dropped down to about 35% in that population who are over 70. So we've got very high levels of vaccine protection against acute zoster, and that goes right out to older age groups, which is really reassuring and now allows those people to be included in the National Immunisation Program. The kind of other main endpoints were the post-hepatic neuralgia, and there were small numbers of cases. So the combined vaccine effectiveness in the 50-plus study was 91%, and then it was very similar in those over 70, where the confidence intervals overlap. And there's some other sort of complications. So we look at autoimmune disorders, we look at stroke, we look at things like like ophthalmic zoster and others. And again, you're getting above 90% vaccine protectiveness in those groups of people that actually had the recombinant zoster vaccine. So this study is actually showing that out to year 10. So if you have a look at the years 9 and 10, while there's a slight decline, and there's actually a bit of a drop-off in the last 2 years, some of that has been attributed to the fact of the follow-up because they were occurring over the period of time that we're having active COVID. But still, the effective vaccine effectiveness over 10 years is close to 90%. And Tony Cunningham has said they've looked at the immunogenicity data, and they're actually seeing, which is shown a bit in the next slide, these are your T cells response. You can see there's virtually no decline in the T cells. So the T cells are actually more important than the antibody levels, because they're going to give you that cell-mediated protection. And there's been virtually no decline in the immunogenicity, which gives us reassurance that this is likely to last more than 10 years. There's no country in the world that are actually recommending a booster at the moment, and GSK will continue to monitor the study to look at the endpoints to see what's actually happening in terms of the level of protection. So we look at the side effects, and this is divided into the two groups. So the people in the 50 and over are in the purple bars. The people in the over 70s are in the kind of maroon bars. And what we see quite commonly in studies of vaccines in older people, that older people have less effects. So these are the local adverse reactions. So it's very likely that someone's going to have a response. And so if you're over 50, 4 out of 5 people are going to have something like local pain, and to a lesser extent, redness and swelling. So they're going to need to be warned about that. And these typically last 2 or 3 days. If you look at the hatch bars, these are what we call the grade 3 reactions. And you can see that generally they're about 10% of the population. And again, the incidence of that lasts probably only 2 to 3 days. So it's very reassuring to see that. If we have a look at the systemic reactions, having any sort of response is very common. Over 50% of the population, and perhaps 2/3 of those over the age of 50 are going to have some sort of response. And so the commonest are things like fatigue, myalgia, and headache, but you can have GI, shivering, and other effects as well. And again, the incidence is lower in those over 70 than the over 50s. And if we actually have a look at the grade 3 reactions, again, they're pretty low down in terms of 10% in the over 50, but dropping to about 5% in the over 75s. This is a bit of a complicated study, but I can summarize it fairly readily. So some people get a severe reaction. So after the first dose, and you need 2 doses to get a good level of protection, the kind of getting a grade 3 reaction, about 5% of the total get a severe reaction. Within this group, 2/3 of those will not have a severe reaction the second time round. So the clinical take home for that is if a patient has a bad reaction the first time, then 1 in 3 of them will have a similar response, but most of them will have a lesser reaction. And in the original pivotal studies, people followed through on getting the second vaccine, but you may need to kind of persuade people that's really important. And one of the reasons you need to do that is that largely you're going to get the levels of protection. You need 2 doses, which is what this slide is showing here. So if we look at the CD4 counts, and we can't easily do this clinically, this is kind of a research measure of the level of protection, you can see that the real protection comes after the booster dose. So you have the priming dose, the booster dose then primes those altered T cells, so you actually get a level which is protective. And as I showed in the earlier slides, that lasts for quite a period of time. So you need that second dose. If you are immunocompromised, you can get that within a month. If you are an immunocompetent person, then typically 2 to 6 months is the ideal time to get it. Just highlighting here, and people will be able to follow this up, the immunisation handbook has really improved the information it's offering to people who are immunocompromised. And for several reasons. That's a growing group of people as people get older. And secondly, availability of a lot of the biologic agents or the disease-modifying agents are altering people's T cells and B cells, which has an impact on their effectiveness of their vaccine. So it's really clear for someone who's immunocompromised to have a look at this, because in terms of the timing of giving vaccines and the impact in terms of their risk is well highlighted in the chapter. So the groups with the red rectangles around them, these are the 4 groups where the immunisation, so on the immunisation program have been able to get free vaccine. And they're just showing you the rate of increase of zoster against the baseline. So this is about 6 per 1,000 patients. And if you have a look, things like stem cell transplants, it's multiplied by about 7-fold in that group, followed by these other things like hematological malignancy, HIV, solid organ transplants, and people who've actually got solid organ malignancy. Tony Cunningham very usefully put this group together, and what he's done is to try and categorise the degree of immunocompromise, which gives you some idea about the likelihood of people getting zoster once they've developed this condition, either from the disease itself or because of some of the treatments. And you can see that the groups that we've actually now putting on the NIP are in this most severe group. There's another group that some of you will see. Those of you who've got rheumatic, people saying rheumatologists, the JAK inhibitors are used for a range of conditions now, and they are very potent stimulants in people getting a bout of zoster. And so those groups, if people are taking JAK inhibitors, it's really important that they actually get protected. There are other groups of people, and you would have seen this with the live attenuated vaccine in terms of low-dose steroids and azathioprine and methotrexates. And while it's recommended, this has now been updated because this was dated in 2022, that all these people are going to get zoster, but these people are at the moment not going to be eligible under the NIP. So this is, again, a bit complicated. This is showing the vaccine effectiveness in these populations. And so this is the vaccine effectiveness based on the CD4 counts. So if you actually have a look at the groups, look at the red rectangles again, because it's the CD4 count that's really important. So if we look at HIV across the board, 90% level of maintaining good levels of coverage. If we actually look at autologous transplants, again, 93%. It's a bit lower in the solid tumours, and that may relate to the timing of when the person got the vaccine compared to their chemotherapy. So we need to have a further look at that over time. And in terms of the clinical impact of that, we actually have clinical data with autologous transplants. In terms of overall vaccine effectiveness, it was around 89%, and it does vary just a little bit between the two age groups. We've seen it overall for hematological malignancy. The numbers are smaller, so we don't actually have that broken down by the different groups. The other groups we're waiting for clinical trial data, and GSK is working on it as we speak. Now, this is a bit complicated, but there's a take-home message. This is the local side effects in the populations who are immunocompromised. What I've then put in here is I put the red bar in to show you what the rate is in people that are, who are non-immunocompromised, who had those sort of reactions. And you can see that you're going to have reasonably high levels of responses in the groups of people who are, with these various other conditions. And if we look at the systemic effects in this particular slide, I've actually put in the rate. So in the over 50, 66% had any form of local systemic reaction, 53% in those over 70. You can see that the rates of systemic reactions, particularly in HIV and in the other conditions, is higher than that, so that they're going to have more systemic reactions in those groups of people. But you can also see in the placebo that the rates are relatively high. So these are people that are really reacting with their altered immune systems. They're going to have a greater kind of systemic side effects than the population that are immunocompetent. Let's get on to talking about coverage. So it's been a really lukewarm response to that, and there are several reasons for that. The Australian Immunisation Register started for older children, adults and older people in 2016, and it's been a huge task to get all of those vaccines recorded, and it's really only been required for some of these vaccines for the last few years. Early on, when a group of us actually looked within 2 years of the program starting, we found that around 2018-19, that something like 60% of the vaccine, in terms of estimating the vaccine distributed to practices and assuming that most of it was not sitting in the fridges, which we found anecdotally was the case, that we could estimate the coverage to be about 60%. But this is recorded based on the Australian Immunisation Register, which is showing it's a significant unreporting, and some have estimated it could be almost half of that. I think that's probably an overestimate. So if we kind of did a best estimate and said, well, if it was about 30% above this, then we may have vaccine coverage levels in the 60% mark, which is still not adequate. I think this new vaccine where we can be confident to give it with people that are immunocompromised, and similarly that we've actually got older populations who are very high risk there, that we should get really good uptakes, and we really need to aim to get above 80%. So the lifetime incidence of zoster, we've said, is 1 in 3, 1 in 2 if you get to the age of 85. Zoster complications like PHN are not prevented by antivirals. They're only modestly reduced in terms of ophthalmic zoster, and they're hard to treat. The best way of avoiding zoster complications is to vaccinate. We have good randomized controlled trial evidence that the recombinant vaccine does that in terms of preventing PHN and ophthalmic zoster. So we've now replaced the live attenuated vaccine. We have updated guidance, and we know it's immunogenic for these groups. And from the work that I've done and others have shown overseas, largely we can improve coverage by having a recommendation either from your practice nurse or from you. And so it's indicated for those over the age of 50 or those over the age of 18 who are at increased risk, and we've outlined those 4 immunocompromised groups. And largely the main contraindication is allergic response to a dose of Shingrix or one of its excipients, and this is really uncommon. Just a reminder for those that are immunocompromised, the time interval can be as short as 1 to 2 months, I mean, certainly by 2 months after the first dose, to actually get good levels of protection. So what do we know that might increase it? So this is based on the study I did a number of years ago and presented in Durban at one of the infectious disease conferences. If we look at the top, none of this would surprise you. So the top category, that part of the table, are those where you're going to get a lower uptake. So if they don't believe they're at risk, and the answer to that is that 95% have got it in their system, and you can't affect your T cells, that's going to decline no matter what you do. Know how much exercise you do, what sort of diet you take, and the like of it. Not needed, as they're really at risk. Well, age is your biggest risk factor. Immunocompromised is one group, but older people are still going to get it. Natural immunity is emerging, and that is not the best way of doing it because you get all the other side effects with that. And in contrast, people who have the regular vaccine, they're much more likely to get it. They need to know about the effectiveness and the side effects, and I provided that data to you. We've talked about the allergic reaction. That's very uncommon. It cannot cause shingles at all. That is not possible. Importantly, sometimes GPs haven't mentioned it to people. In other words, if you don't talk about it, the person assumes that you've actually decided that it's not, or they've decided that you think it's not important. So you actually sometimes need to encourage them and to actually proactively raise it. Those who are more likely to get it if they're older, if they're female, high level of education, regular vaccinators, awareness, so being aware of all of that, where that can be a serious condition, have a usual GP actually helps. A strong recommendation, and I'll show you some data from that in our kind of multivariate analysis, after adjusting for everything else in our sort of Zoster study, they're 10 times more likely to get it. This is sort of complicated, but let me just take you through it. This from our study highlights a couple of key points. First of all, that some of these attitudes are fairly common. So anything in red is what we might regard as an issue or a belief that might end up being problematic for vaccine. So if we take it the one, I could get shingles from the vaccine, 48% of people, nearly 1 in 2, are not sure about that or might even agree with it. And if we look at the vaccine recommendation, if there's nothing from you, then 48% of them will get the zoster vaccine. If it's recommended, despite them having that belief, nearly 74% will get, so that they don't even have to change their attitude. Just with you doing that, you tend to overcome that. If you take down to the bottom one again, I do not need a vaccine as I rarely get sick. 40% of the population would say, well, that might be true. I'm not sure about that. If they believe that, if they're unsure or agree, about 1 in 3 without a recommendation from you will get it. That will double if you actually make a recommendation. And so some of the things I talk about as a strategy, have your 1 minute response to each of these things there, about how you're going to counter that in terms of like allergies really uncommon. The fact that quite often with the local side effects, people are going to be persuaded by you actually saying something. And then secondly, if you can actually talk about the maintenance side of things, so that, I think the chaps particularly respond to that. We all put, we take our car for a service, we change the engine oil. It's relatively inexpensive. We know that if we go on a long trip, we're less likely to break down. Well, people do their things with their diet and their exercise. Having a vaccine is another way of boosting your immune system so it doesn't break down and you actually get zoster. If we just go to the survey, and thank you, Andrew, and the team for doing this, and thank you for the respondents that replied, to help me kind of provide some guidance about what we might be doing. What are the numbers here? And so we've got responses from both states. You can see that by and large, 50% of the people attending tonight have got about 500 people to vaccinate. But something like nearly 40% of those have got nearly over 1,000. Or over 500 to vaccinate. And so in our practice, where I go, the practice manager ran and they said they've got 2,000 people because we're in an older neighbourhood. So they're going to have to really have a program. Reassuringly, if we look at in terms of these conditions, and I'd be asking you, how do you know these? And I would suggest you set up a register. But by and large, for people who've had stem cell transplants, sort of 85% if you've got less than 20 patients. For solid organ transplants, 95% have. If we look at hematological malignancy, again, 80% if you've got people or less than 20 patients. And with HIV, a very small number. So I would suggest in your priority setting, these groups are not going to take up a whole lot of time. They're very high risk. And I would be aiming to try and give them some degree of priority. And the people who've been waiting a long time, obviously they need it. But these are the people that are going to be very likely to get shingles in the near future, and it might have a very devastating consequence. So, questions. I think we've left lots of time for questions. I'm happy to take ones from the floor, and if there are, I can throw up a few if you haven't, if there aren't any forthcoming, particularly having recently attended the NCS All-Stars session on Shingrix and the vaccine from Christine McCartney, Betty Lou, and Paul Kelly, which was a really good session. I don't know if it's still available, but that was run at a lunchtime, and it's worth having a look at. But I've got some of the questions from there, and if they're not raised, I can hopefully answer them. So, Anastasia and Andrew, back to you. Shall I stop sharing my screen for the moment, or shall we just leave it as it is?
You can stop sharing your screen.
Okay.
Thanks, John. A very detailed and comprehensive overview. I mean, we've been very lucky of all of the content that you've provided. So there has been a number of questions. There's been a lot of early questions have been answered in your presentation, but I'll just pull out some. And again, if I don't get to all the questions, then we will be providing a document next week that'll answer all the unanswered questions. So why, hang on a second, if much higher risk at 50 years old, why is it not made free on the NIP for non-Aboriginal patients at 50 years and older? Why is it 65?
Well, I showed you the highest risk is the older you get. And I also highlighted that your incidence doubles from the age of 50. So whatever your incidence is at the age of 50, by 65, it's going to be double what you are at 50. The government have already committed $800 million in very austere times over 4 years to do that. And they haven't just gone, like with the pneumococcal vaccine where they're only offering the age of 70. They've gone over 65 with no restrictions. So I think, yes, you are at risk. You are eligible to get it over the age of 50. You're just going to have to pay for it. And it will probably cost you to spend somewhere around $600, for which you'll get something back for the from if you've got private health and cover. It can be quite modest, and it does vary a lot. You'd need to check with your own private healthcare fund in terms of the extras.
Thanks. Yeah, it's so I'm 56. I know that I look significantly younger, but I got a private script and my GP recommended it to me. So I've had my first dose 280 times 2, so I'm due for my second dose, but I don't have private health insurance, so 560 is what we paid, or what I paid. So a 51-year-old patient had a first dose of private script again, of course, of Shingrix vaccine in July. In October, the patient had a bout of confirmed shingles. It was rather somewhat mild. When should this patient have the next dose of Shingrix?
So I assume they've got Zostavax the first time, or do they get Shingrix?
Shingrix.
Okay. Well, they should have it, despite having Zoster, within 2 to 6 months of their first dose. So you're saying now they had Zoster in October of this year?
No, they had Shingrix vaccine in July.
Yes.
And then they caught shingles in October. When should the patient have the second dose of Shingrix?
Which they should just still follow the regimen. I would say 6 months. So they had it in July, in early next year. You'll get a little bit of a boost from the wild dose there, but I would say 6 months you should get the second dose. That's a bit. Did they have it confirmed? What I'd be questioning that is that you get some degree of protection after one dose, but it would be worthwhile to ensure that the GP had actually confirmed that.
It did say confirmed. It did say confirmed. Yes.
Okay.
So the best time to receive a second dose, if you're not immunocompromised, is between 2 and 6 months.
Correct.
Is there better efficacy at 3 months rather than 6, or should we be
No, the studies were, the data was clumped together, and the 2 to 6 month window is fine. The other thing, they did immunogenicity data out to 12 months, and they looked at that. And so if someone got delayed for whatever reason, so let's say they had their first dose and then had some event where they were immunocompromised and had to wait, well, that might affect it. But, the immunogenicity response, even 12 months out, you get the benefit. But both the main clinical trial data is between 2 and 6 months. So any time between that is fine. There's no particular preference to say it should be at 2 months or 4 months versus 6 months.
Okay. This is more of a co-administration question. So with Shingrix, and this is really covered, I see on the NCRS website, the ATAGI website, and in the Australian Immunisation Handbook. Where can you co-administrate other vaccines with Shingrix, such as flu or influenza vaccine?
Okay, so you can give the pneumococcal vaccine. You can give an unadjuvanted flu vaccine. The challenge is over 65, most of it is adjuvanted. And what I'm saying is that you're going to have a very high local reaction rate with the Shingrix, even though it's going to be in the opposite arm. I would say in terms of the COVID vaccines, while the government is making it clear you can co-administer them, you're just going to have, because people often have quite a few reactions to the COVID vaccine, particularly the mRNA vaccines, you're going to have both arms being sought, which may be an impact. So yes, you can co-administer them, but I would suggest perhaps a wait to get over that. But some people just want to get it all over. If they're going to have to take a few days off, you might as well get the 2 vaccines, and obviously you have them in a separate eye.
Thank you. Can a patient have Shingrix when on high dose prednisone or having an immunosuppressant?
Yes, they can, but the challenge is in terms of the timing. They need to talk to the person's their specialist who's managing that, because a high dose of that is going to be immunosuppressive. But we've seen from the study some of those groups are in that trial where they've high dose prednisolone. And so ideally, you'd look at the timing of that. But if the person is at high risk, then you try and find a window to do that. They're not going to get acute varicella from having the vaccine. That's the real advantage of a recombinant vaccine. But in terms of it actually providing clinical benefit, if they're much more immunosuppressed, but having said that, the studies I've shown you, they've actually got pretty good levels of protection. Talk to their talk to their specialists who's organising the steroids. But in the default would be not unreasonable to provide them with that vaccine.
With NIP funded against the 4 immunocompromised areas, stem cell transplant, organ transplant, and HIV and so forth, I see that renal disease has a relative risk similar to that as HIV. Do you think renal disease could be added to the NIP?
Look, GSK are looking at all of those groups, and they were largely looking at them at the level of risk and the numbers of people affected and the frequency of shingles. I'd have to go back and take on to see what the renal studies are. I haven't been looking at that directly. So it will evolve. I mean, talk to your local GSK person, and ATAGI will update the advice, but they will be particularly interested in having immunogenicity data in the first instance, and would be pushing GSK to provide clinical trial data for that. So you can still try and persuade the patient, but at the moment they're going to have to pay for it.
Yeah, okay. This is from Carol. With increased in COVID-19, and that's circulating again, is there a recommended waiting period after COVID-19 infection?
Not really for that. I mean, you probably, like with a lot of things, give it a couple of weeks until you're over the worst of it and you weren't acutely febrile and whatever. It's interesting. I could put my slides up again, but COVID increases the likelihood of people actually getting zoster. So your risk of zoster goes up by about 15% after a bout of COVID, and your chance of being in hospital. And so ideally what you'd want is 2 things. You'd actually want someone to get their zoster vaccine early in case they did get COVID. And, the COVID booster will also reduce that risk.
So if you've had your first dose of Shingrix and for some reason your second dose is delayed for a year plus, is the recommendation just to get your next dose as soon as possible, or
Yes.
is
Yeah.
there a point where you have to start again?
No, I think the best thing would be just to get it as soon as possible and try work hard on avoiding that situation.
Okay. We're kind of running out of questions.
If you give me, I'll go back to sharing the screen and just, I'll see if I can take down to think that there's a couple of others in terms of the timing. And so I'll just need to flick through these.
There's a question here from, while we're looking at that, from Anna. Is the history of, excuse my pronunciation, Guillain-Barré,
yeah.
a contraindication to Shingrix?
Now that's an interesting question. Let me just, what's going on here? I don't know. I'll just have to, Guillain-Barré is increased after the zoster vaccine. I need to find my slide there, Andrew. Let's see, because we're not getting that at the moment. The Guillain-Barré is increased slightly after getting a shingles vaccine, and the incidence is about 3 to 6 cases per million doses. In that situation, between 43 and 63,000 cases in that 1 million population would have had avoided getting shingles or its complications. So the net benefit is to get it. If someone's had Guillain-Barré, then you need to talk to your neurologist about that to see specifically where they should not get it for that. And I'm just trying to, I can't see where the, I'm just looking for my, oops, today, where is it?
I think they were in your backup slides off memory.
Yeah, I'm just, just. Let's see if I go from here.
So another one's popped up. If you are able to scroll and answer, if you can do two things at once. A 70-year-old female patient, this is from Wailu, was certain she had never had chickenpox, and tests showed that she had no antibodies at all to the varicella-zoster virus.
Yeah, she needs the varicella vaccine. If she's serological negative, unless she's had some immune condition that suppressed her response to that, and then you'd have to sort of wonder, because that can happen. But if that's not the scenario and she's got no serological evidence of zoster, then she needs a varicella vaccine.
And that was her question, so thanks for that.
Yeah. Now here's the slide. And so the US got a signal for Guillain-Barré, and then they actually looked at their large databases, and they looked at several million population. And so again, the key messages are highlighted in the red rectangle and the green rectangle. And so what I was saying is, if you take let's take a 60 to 69-year-old, depending on the database you looked at, the incremental additional cases of Guillain-Barré per 1 million people who had a zoster vaccine and these are in a 10-year age cohort, so that was the increase that was offset in that same population. So we look at the 70 to 79 by about 63,000 people who did not get zoster or the complications of zoster, which includes some of the Guillain-Barré complications. So the basis on that, the American equivalent of the TAGI ACIP have decided that's a very minor event. But for someone who's had Guillain-Barré, it's quite a worrying diagnosis, and people have a variable recovery from that. Many recover fully, but some take a long time to do that. I would check with their neurologist and get further advice about that. The other thing, just to highlight, and I think occasionally I've been asked about cancer. This is data from the NCS group. So Quinn was a postdoc there, and Christine McCartney and Betty Liu have been, they actually had a look at the large database in Australia, and they said, is there a signal for zoster prior to the diagnosis of cancer? And here they've got solid organ cancers, and they've actually got hematological malignancies. And if you look at the dashed line, you can see in the 2 years leading up to the diagnosis of cancer, people had a higher incidence of zoster. And if we go and then that rate increases further after the thing is diagnosed. And so the reason why it goes up even further is that not only have you got the disease where the person's T cells have been modified, you're now treating them, which further influences their immune system, so the rate goes up. But if you look at the study, so that this is a bit complicated, but you can see there have been 2 large Taiwanese studies, and it's been not clear, but there was an increase in one of them to show in lymphoid malignancies, which is part of the blood cell cancers. The Netherlands showed in women who'd actually had it, that they, women who had zoster, there was a slightly higher incidence of malignancy. But in the kind of stuff that we've seen here in the Australian one there, they very clearly showed that the hematological malignancies were increased in that group. And so I think the message is if someone is getting more than one bout of zoster and they're otherwise well, it should really prompt a health inquiry to see that the other person's well, because it may just be a marker their T cells are not working for other reasons than getting older. It actually may be related to them having an underlying malignancy.
Thank you. There's been a number of questions, actually. We've got just a few minutes. Is there any benefit, and there's no upper age limit for getting your Shingrix vaccine, is there a benefit for someone who's over 80, over 90, over 100?
Look, whatever age they are, if it was my grandmother and my father's mother lived to 103. So, you are very high risk. And we've got evidence over 90. I mean, I don't know how big the sample was in the over 100. It'd be fairly small, but I would say anyone over 90, it's worthwhile getting. The issue will be is that while the vaccine in the group that we've seen is very similar, vaccine effectiveness to those 70 and older, we know that your T cells further decline. So anybody who's older, I would get in sooner rather than later. But anybody who happened to ask me, I would say it's reasonable. It does reduce the risk.
Last question. Are you at risk if you have psoriasis?
That was a very slight risk of zoster, not a priority group.
Okay. I think I've just got a few minutes left, so I might call it there. So thank you.
Can I make a final comment, Andrew? I won't put the slide up, but intriguingly, there was a Welsh study that people who have the zoster vaccine have about a 17% reduced risk of dementia over the 5 following years. And they did an ecological cohort study because everybody got offered the zoster at the age of 70. And so that was a natural experiment. They had to look at the people that didn't. And so it's been interesting. And there's been some data now that those that have actually got the recombinant vaccine, that it's very similar. And so, the mechanism is hard to do. We can't run a randomized controlled trial, but you can actually suggest that if you want to reduce your risk of dementia, another reason to get the zoster vaccine. And that's certainly on the cards for a lot of older people.
Okay. Thank you. Just a couple of take-home messages, really. I would say that the strongest recommendation to get your Shingrix vaccine is from your healthcare professional, particularly your provider.
Absolutely.
That goes a long way, and sometimes you just need a little nudge. And the best way to prevent shingles is to actually be vaccinated against shingles. So it's preventative maintenance, if you like. We all do it with our cars. Why wouldn't we do it with our bodies? So thank you again, Professor Litt. So again, also thank you to the audience for your participation. We've got just 1 minute left. Anastasia, can you just bring up that one slide, if you don't mind? Or I'll just talk to it. So our final webinar for this year is on the 28th of November. It's in the middle there. It's online paired learning with travel vaccines in general practice. An email will be sent to you the next couple of days, or you can see it on our website. You can register for that. It's CPD accredited for reviewing performance for 1 hour for GPs, and for other healthcare professionals like nurses, it's self-accredited, and we will also provide you a certificate. And a plug for next year's 25th annual scientific meeting, our Immunisation Coalition 25th annual scientific meeting. That is on the Sunday the 4th and Monday the 5th. You can find those registration details on our website as well, but we'll also be sending you out an email. It's a 2-day event, has a number of speakers, and there is a number of panel discussions as well within each session. So you're welcome to register for that event, both on site and online. So it's a hybrid event. So we're bang on time at 7 o'clock. I'd like to wish everyone an early Merry Christmas. It is quite early, but still, and Happy New Year, and enjoy the relaxation and come back fresh, and we'll see you in 2024. Thank you and good night.